Okay, good. Thank you. All right, so let's okay, so let's make a start. Thank you so much, everybody, for joining the seminar. Those of you who have been with us before, you would have noticed that there's a change in the format. We went from webinar to a regular kind of Zoom meeting, and the idea was to make it a bit more interactive and you know, to see you out there as well, all the participants. So that was the idea, and hopefully that will work well. And so we can from now on we can change to this mode. It is my great pleasure to introduce Kompal Sinha, today's speaker. Kompal is a good friend of GLO. She's one of the 5 advisors on our virtual Young Scholar program.
This is something I have noted in the point d'accord, désaccord, just for you to know. So, and then, so that's good, because I have seen also the questions.
Could you mute yourself, please? Everybody who has come in, could you mute yourself?
Do you see my email?
I don't know who that is.
You can mute them.
Yeah, I'm trying to figure out who this is.
Yeah, maybe you can go into the participants and just mute people if they're still...
Well, I just looked at everybody and they seem to be all muted, but anyway, so this person is muted, so hopefully that'll be fine. So I don't know where I was. So thank you so much, Kompal, for agreeing to present. As I was saying, I think before that, Kompal is a good friend of GLO. She's one of the 5 advisors on the Virtual Young Scholar program as well, which, by the way, the applications are open for next year. If anybody's interested, the information is on the GLO website. And also especially thankful to Kompal to agree to present, because it's, as I was saying before to her as well, it's at 10 o'clock in the evening for her, and it's not the ideal time to talk serious stuff, you know, especially in kind of a Zoom kind of session. So it's really great that that you have agreed to present. Just as usual, a couple of things before we start the presentation. Please use the chat function to write your questions during the presentation. But Kompal will address all the questions at the end of her presentation. But if you have anything kind of clarification type questions, you can ask you know, on a particular slide. You can interrupt, but only if it is a clarification question. Because we are trying to make sure that we finish, you know, sort of by 11 o'clock her time. And also just to make sure that everybody knows that the seminar is, as usual, being recorded, and it will be available along with the paper tomorrow or by Monday. With that, I pass the virtual floor to you, Kompal. All yours.
Thank you very much, Matlub. Thanks for having me. It's a great pleasure to talk about this paper today. And as I said before, it's been accepted at Health Economics this morning, so we are kind of full on with this one. So yes, any questions, do stop me or have them. It's mostly in the sense of talking about the paper, what we did. So I've kept the tables at the end, and we can go through them as questions come in. So as you can see from the title, this is a joint work with Anam Belgrami and Henry Cutler. Both of them work at the Center for Health Economy here at Macquarie University, Sydney. And myself, I'm at the Department of Economics, Macquarie University. And this paper comes out of Anam's work. Anam is our PhD student, and she's trying to analyze what paid parental leave and mental health relates to in the context of Australia. So postnatal depression, I mean, all of us have heard about postnatal depression. It's a difficult time for the family, and once the baby is born, we go through, I mean, all of us who have babies, we go through this phase where we don't know whether to be happy or to be sad. So sometimes that phase is also termed as postnatal depression, and usually it takes place in the first to the 12 months after the baby is born. And something that happens with postnatal depression is anxiety as well, so it coexists. And severe cases can lead to psychosis as well. So it's an important phase, both as a new thing happening in the family and in terms of health as well. So how does that impact the employed workers and employed mothers is an important topic to talk about and to think about. And the ones who are most vulnerable to this postnatal depression situations are the women who are working, and because they're trying to balance their work and family, which can create a lot of stress and a feeling of guilt as well. So if you look at the numbers, the international estimates are that 30% of all women who have babies experience postnatal depression of some sort. And the number is very high for Australia as well, it's 10%. And as I said before, it is a compromise because the ability to care for the children, adverse effects on the parent-child interaction, and the child development and well-being are quite important factors in deciding postnatal depression. Sometimes it can also lead to relationship breakdowns, so suicide and all those kind of things. So overall, it can end up in a very severe health situation. And the fact that not many people have talked about this into the context of health is something that's caught our interest in analyzing this topic. So most studies try to look at it from the labor market outcome perspective, and they try to see what are the impacts of parental leave on labor market outcomes. There's a lot of papers quite recently as well. We have talked about these, but there's not much focus on how this parental leave and these policies that we have would affect the mental health for women and men as well once they have the babies. So they have either tried to see the effect of duration on mental health, how long the leave duration was and how that has affected the mental health. You have individual level studies, you have policy level studies as well. So where you try to see if the access to leave after a policy change, the impact on mental health or not. But these policies could have important implications for mental health, and that's what we're trying to, we're trying to explore over here. This was, okay. So I can't seem to see the bottom of my slide. So, okay. So what does the Australian policy look like? What does the Australian policy look like? So all women in Australia are entitled to 1 year of unpaid parental leave, and if they worked for 12 months before the pregnancy, and some women are entitled to employers' paid parental leave as well. And then we have something what is called the National Paid Parental Leave, which was introduced in 2011. So before 2011, Australia and the US, in that sense, were some of the few countries who didn't have any national plan for parental leave. The US still doesn't have one, but yes, Australia started one in 2011. What it does is that it provides primary parent up to 18 weeks of pay at the national minimum full-time wage, and which turns out to 42% of the average wage. And the requirement is that you must meet the minimum work test, which is 330 hours in 10 months, and an income threshold as well. Your income should be below 150,000. So that's the structure of the parental leave in Australia. In 2013, there was an extension of this policy where dads and partner pay, the DAPP, what we call, was introduced. This was essentially introduced to provide a 2-week at the national minimum full-time wage for partners. And because it occurred alongside the paid parental leave, we were also interested in trying to check how this policy impacts the mental health for women in Australia. So and then the last thing I'd like to say over here is that this also was accompanied by the removal of what we had, a baby bonus. So before all of this was happening, there was something called the baby bonus, which gave people a $5,000 or a lump sum amount if you have a baby, but that was removed and the DAPP was introduced. So this is the policy context of how the PPL works in Australia. When we look at the structure of the PPL, parental leave or maternity leave, or how we want to say it, across the OECD world, we can see here that that Australia is not high up. We're not very good at. We've got the UK, which is doing better, the Greece, which is doing better as well. But yes, and there are quite a few countries behind Australia as well. So what this graph shows is your paid parental leave, the length of leave, and the full rate equivalent. So the length of leave is the gray one, and the full rate equivalent is the red one, the blue one in the context of Australia. And as you can see, both the length and the full rate equivalent in the case of Australia is not very good as you compare to some of the other countries around the world. So, right. So this one shows the paid maternity, parental, and the home care leave, which is available to mothers as well. And in this context, Australia is sliding way down, and it's sitting very close to the United States. But yes, so what we can gather from these pictures is that there is a lot of work that can be done in terms of designing this policy in Australia and around the world as well. Comparing the duration, if you try to compare the duration for what Australia has and what other countries have. So this graph taken from the Huffington Post talks about how US compares to other countries, but essentially you can see that Australia is 126 days and the UK is much better in that sense. And Australia is of course not the best one. So our interest was to see that how this policy has worked ever since its implementation in 2011. Now this one is talking about both the parents. It's saying that how fathers and mothers, fathers showing in the blue and mothers showing in the red and orange, their leave across countries look like. And as you can see from the picture, again, we don't have, Australia doesn't have a very strong policy to support its parents. So what does that study do? Our study investigates the impact of the PPL scheme on mental health of mothers in Australia. And we try to check whether the introduction of the PPL, which was in 2013, has worked when it comes to mental health for women. The one thing that we do in this data set is that we use the HILDA data set. The HILDA data set is the longest running panel data in Australia. It's one of the most extensive data sets. It collects a host of information right from income to labor to health to family characteristics to you name it. I mean, it's one of the best data sets longitudinal. So we use this data set to construct a variable on the PPL eligibility. And the way we do it is, as I explained it a little bit, is that we use the work test, the income test, and the leaves. And the income that we have, all of the eligibility criteria to construct our subsample for analysis. So as I said, it's 10 o'clock over here in case I drop out and you hear me snoring. So you should know what I was talking about. So the results are that we just investigate the impacts of PPL on maternal mental health. And we focus on the study which has previously been done as well. So this paper by Hewitt et al. In 2017, who tried to focus on the heterogeneity across the contract type, the sector, the organization size, and the occupation. And they found a small significant increase in mental and physical health post the PPL was introduced in Australia, right? But their analysis was not as extensive as ours. What we do is we study this this topic by extending to include depression and other subgroups of anxiety, and we use a panel data to account for the trends in maternal mental health to try to see how the type of mother and the maternity type and relationship between the PPL and the DAPP. So when I say the type of mother, I'll explain what I mean by the type and the maternity type as well. So what is the eligibility criteria for this policy in Australia? The government said the PPL eligibility based on the past year work and the income history of the primary carer. There's a work test, which is 330 hours in the 10 of the 13 months prior to birth. This translates to just over a full day of work per week, right? There's an income test, as I said, 115,000 or less in financial year prior to the birth. And you can take a leave from time when one becomes primary carer until the end of the parental leave period. Now, the DAPP from the 2013 has the same eligibility criteria, except that it applies to the partners to the PPL eligible woman. Right. The one thing that's important for our analyses as well is the fact that because this is a national policy, it doesn't have any regional variations. It's not varying across states, which is something that we have to tackle when we do the analyses. So we use the HILDA data set. This has been collected since 2001. The first wave contained information on more than 7,600 respondents, households, and 19,914 persons. Wave 11 was replenished with 2,000 odd additional households. And in wave 16, it contained information on 7,600. It's a healthy sample, good enough for analysis. And the responses ask questions on family, household formation, income, work, and in a lot of detail is available in this paper by Summerfield et al. 2017 for those who are interested. So the HILDA collects a rich set of self-reported health variables as well, and detailed information on calendar-based employment and past year income. Now that's important for our sample construction as well. So as we don't have clear information on the PPL in the HILDA data set, what we have, one of the tasks we have here is to construct a variable which tell us about the PPL eligibility. So what we try to do here is that we take wave 14 to wave 10 for the pre-reform period. So wave 14 would be 2004, right? So it starts in 2001. So we take the wave 4 to wave 10 as the pre-reform period, and then wave 12 to wave 16 for the post-reform period, right? And in doing this, we exclude the 2011 births because the policy was implemented in that time, and there could be potential shifting of women who are having babies. They might want to, have the baby once the policy is implemented, and so on and so forth. So there might be some kind of an issues over there. So we exclude the 2011 data set. And the sample we come up with has lower number of births, but they're sufficient for us to undertake the analyses. So ours is the first study to methodically construct adjusted taxable income and work calendar history to assess the PPL eligibility. The Productivity Commission in Australia has predicted 84% eligibility, and our analysis predicted 87% eligibility for the HILDA data set, so which is quite close and reassuring. Now, this is the variable that we've used for our analyses. It is under the question relating to leaves taken over the past year. As we're considering just a woman, we see that in this graph we've got the pre-reform in the gray and the post-reform in the white bars. And as you can see, there's a decrease in eligibility, eligible women reporting no leave taken, because there were 28% of women pre-reform and 13% of women post-reform reporting they have not taken a leave. Overall, there is an increased paid leave duration from the PPL and the higher proportion of women reporting 18 or more weeks of leave. So that's our PPL variable. The dependent variables, or the variables of our interest, are the mental health variables. So in that context, we've used four types of mental health variables, if you can say that. So we've got something what is called the MCS, the mental component summary. We've got the mental health subscales, which is the FF36, the mental health inventory, the MHI, and some depression thresholds. Now, because these variables are self-reported, there could be some measurement errors that kind of are talked about in the literature by Richards et al. And some other papers, which can be a matter of concern. So what we try to do is we try to take a more expansive set of outcome measures, which include a continuous measure, which is the a depression severity, and the SF36 measure. So the MCS is based on items across the mental health, the vitality, social functioning, general health, and role subscales, which would relate to the emotional aspects of your well-being. Then we construct a 4-category threshold measure following Yamazaki et al. 2005, in which we divide the MHI into 4 thresholds with no depression, mild depression, moderate depression, and severe depression. So these form our dependent variable, the range of dependent variables. So if you look at the trends for this MCS variable, running from 2004 to 2016, we notice there is some kind of a decrease in the mental health score happening over here. The fluctuation in the graph is essentially because of the small sample sizes that you would observe, as I said before, but overall you can see there's a downward pattern happening over there. For the rest of the health scales also, we can see the similar pattern. It's, of course, there will be some variability depending on how it's measured, but yes, the trend is a downward trend. So mental health has worsened over time for this eligible sample. And because of this trend, we feel that there's a need to control for the time trend in our analysis as well. So, so the data that we have also indicates that there's a prenatal and pre-pregnancy levels of mental health that are strongly correlated with post-birth levels. And the eligible women have the best levels of mental functioning during the prenatal year and birth level immediately following the birth. So there's a lot of evidence that we are observing about poor mental health post the baby birth. In terms of treatment and control groups, so we construct a sample of PPL eligible women with partners giving birth before and after the PPL reform. We call the pre-reform group the control group and the post-reform group a treatment group. There were a total low numbers of annual recorded births in Hilda. So we had to boost our sample by pooling births in the year around the reform as well. So that was a extensive analysis, and I can talk about it later if people want to talk about it. So pre-reform and post-reform essentially driven by the timing of the policy, the data availability, and baby bonus, which came out in 2004, the reason that we tried to include it just the wave 4 onwards and not anything before the wave 4, because if we had anything before the wave 4, that means we would also be talking about the baby bonus policy, which was introduced around that time. So right, so that's my data set. So how do we construct the PPL eligible sample? We use the definition or the eligibility criteria, take a labor market calendar in HILDA, which contains information on the time spent in jobs from month prior to the interview to July of the previous financial year. And HILDA asks women who gave birth over the last year as to how long this, before the date of interview, this was happened. We have the range of 0 to 3 months, 4 to 6 months, 7 to 9 months, and 10 to 12 months. Then what we do is that we take the, approximate the midpoint of these ranges related to the interview date, and that gives us the range of error of 1 month around, but that's the best we could do, and we've done. So the birth month and the calendar data used to estimate the whether men were working. Data for up to 3 jobs were used, so people can work in multiple jobs. So then we decided to use just the first 3 jobs that the people are reporting they were working on, to check the employment over the last 13 months period. And then we applied the HILDA tax benefit model to estimate previous year ATIs, and we assessed it against the PPL income thresholds. So at the end of it, we had to exclude 210 births from the overall sample of employed women, because either they were above the income threshold or they did not meet the work test. Final pre-reform sample had 732 births, and the post-reform sample had 748 births of partnered eligible women. Our total sample was 1,480 people. As the one thing that was interesting for our analyses was that the post-reform sample had a slightly higher number of births as well. And this was despite comprising 2 less waves. So we had 2 less waves, but they had a slightly higher number of births. And that was due to the increased recording of births in the HILDA over time, rather than the selection into the post-reform period. So for the control variables, we use 2 sets of control variables. We said a core set, which includes the basic sets that you would have from a dynamic health outcome analyses from the literature. And then we have an expansive set, which adds more variables to the core set. So those variables included women's pre-birth job characteristics, the matched partners, education, the job characteristics, did they have any partner and family support, what kind of life events that may have caused temporary fluctuations, what was the quality of their job that may influence the postpartum mental health. And all of it was motivated by the fact that stressful life events and social support are both quite significantly associated with postnatal depression. We also had income in the past year as the partners and the partners' income in both sets of variables. And as somebody might ask me, that there's possible endogeneity between income and self-reported mental health, which has been quite popularly talked about in health economics. So what we do is that we assume income and health are not simultaneously determined in our estimation, because we are using the last year's income, whereas a mental health variable measures the recent changes in mental health. The mental health questions always ask, over the past 4 weeks, what was your mental health like? So in that sense, because we're talking just about the past 4 weeks, income is past year, so we kind of conveniently assume that income and mental health are not simultaneously determined. Whereas yearly income may impact mental health as well, right? So it could be implausible for recent mental health to influence past year income though. So yes, the other thing that income variable has is that it includes various forms of non-labor income, and that is unlikely to be endogenous with health as well. And there's some literature that we've talked about in the paper which supports that that claim. So what we do is that we include lags of the dependent variable across both sets to control for the pre-existing mental health condition and the baseline mental health levels following the literature. So what are the methods that we adopt to do this analysis? Now, as I said before, there's a huge lack of regional variation, unlike a study in the US or somewhere else where you might have variation across states for a policy that will allow you to do a nice causal analysis. We don't have that for this current PPL policy. What we do is that we adopt a pre-post estimation approach to estimate the policy effects. So now these methods are not new, of course, and they're being used for parental leave effects on health and labor markets using national survey data. And these are the few studies that have tried to use the pre-post estimations approach. So all of that data and all of that variables that we've created, we try to estimate using the OLS for the MCS and the ordered logit for depression and subgroup responses to the SF36 instruments. So what we do is that we've got the outcome variable, which is your MCS depression subgroup response to SF36. We've got the post variable, which is a dummy variable on whether the mother gave birth / adopted in the post-reform years. And then we've got lagged variables for the dependent variable, which is the second lag and first lag and the second lag for that year. We've also got a time trend there, and then we have the standard vector of covariates. So for the autologit, which also has a latent variable kind of understanding, what we do is that we take the probability of selecting category conditional on the covariates. And once that is done, we use that this functional form to do our estimation. The difference between the first and the second coefficient, which is your beta over there, right, captures the after difference in the mental health outcomes between women who with births in the pre and the post reform period, which is the policy variable of our interest as well. For the DAPP analysis, what we try to do is that we see whether there's an additive effect of maternal mental health outcomes from the PPL schemes. So the DAPP was introduced as a complementary policy to the PPA, right? So then we narrow our sample to eligible mothers whose partners have concurrent access to DAPP in the post-DAPP years. So once the DAPP was introduced in 2013, we tried to see that of our sample, what is the subsample for eligible mothers who also have partners with access to DAPP. And then we do a subgroup analysis on the first-time mothers and mothers with pre-existing leave entitlement. And for the first time, our analysis, I mean, this is the first analysis again for for trying to analyze the differential effect of parental leave based on mothers' prior birth experiences. And we also do the duration effects of all of that. So
Kompal, there's one kind of question by Heather Brown, which might be appropriate to ask now. She says, do you control for previous number of children?
Yes. So we have. So I'll show you when I'm just talking about the results. We have mothers who have had babies before, and then we have another sample for mothers who have their baby for the first time right now. So those are the two types of mothers I was talking about. So yes, I will talk about that. So yes, we do control for for having previous births, but that is by the sample of mothers who've had previous births rather than including okay. So so what we find in our results is that the policy does have an impact on mental health over the entire post-reform period, which is 2012 to 16. There was a significant decrease in the depression severity, which translates to 14% reduction in the likelihood of depressions, of all depressions, in fact, of all the categories of depressions that we have. The policy effects for the MCS and the individual SF36 mental health suggest there's an improved mental health outcome, and they are insignificant, however, at the 10% level. Thinking about the years after the DAPP was introduced and eligible women with access to the DAPP, for example. So now we find there's a larger significant improvement in the depression severity. So with the PPL, we only noticed that 14% reduction in the likelihood of depression, whereas when we include the extended policy, which had the DAPP as well, there was a significant improvement in depression severity, which translates to 18.5 reduction in the likelihood of depression. So there is a clear sign coming out of the benefits of policy of the PPL on mental health. Yeah. So the improvements in the MCS hold across covariate sets. So we have all the covariate sets in
We can't hear you, Kompal. I think you have muted yourself.
I'm just trying to move
yeah.
that black bar around so that I can see what I'm talking about. So yeah, sorry about that. So yes, so there are improvements in the MCS which hold across covariate sets with or without lags, and there is a nearly 5-point increase, which all of these results suggest that the DAPP may have a supplemental mental health gain from the PPL. So now it comes to the test, right? That how robust are our tests, are our results. And so as a test, we estimate the model, the main regression model, using just the post-DAPP years, which is 2014 to 16, and consider this as a post-reform wave. But first we do it without narrowing the eligible sample to those DAPP eligible partners. What we find is that mental health gains are smaller in magnitude and significance than what we found after narrowing the sample to eligible women with just DAPP eligible partners. Partners' concurrent access to DAPP, we suggest, may be supplemented the mental health improvement from the PPL scheme. So there's a. So the next question that comes to mind is what was being asked just now, is that what happens to first-time mothers versus experienced mothers? So what we try to do is that, all right, just see whether they've had previous births. So that's the benefit of having the longitudinal data set as well. Not only could we just check how many births or children are reported, we could also figure out whether they've had babies before or not. So we explore whether the policy impact differs across first-time mothers versus experienced mothers. And then we also analyze the impact of mothers with existing paid and unpaid leave entitlement. So compared to those who did not have any of those entitlement. So how did we do that? We did that by including a dummy variable, which integrates the group membership. When I say groups, I'm talking about these groups, which are interacted with the post-reform coefficient in our equation. So in our eligible women sample, we had 765 births for first-time mothers, right? And 715 births for experienced mothers in the pre-reform and the post-reform period. And for these samples, we find that there's a significant mental health improvement for first-time mothers as opposed to insignificant changes. Sorry? Is there a question?
No, carry on. I think somebody was.
Okay.
Carry on.
Yeah, so there was a significant 3-point increase in the MCS as well, and a substantial improvement on depression severity. And one of the items was felt so down in dumps there, and all those marginal effects and the results are there in the paper as well. So the next question that might come in mind is that what about women with leave entitlement access? You know, these are the more advantaged ones, and these are the women with both employer paid leave and unpaid job protection. And there we find they had a significant 3-point increase in the post-reform period, and compared to insignificant changes across all other groups. They had significant improvement in depression severity as well, compared to the insignificant results for the ones without these entitlements. Women with access to employer paid leave had greatest mental health gains, with 14.2 to 16.7 reduction in the likelihood of depression. And women with no access to entitlement increased their leave from 5 weeks pre-PPL to around 9 weeks post-PPL. And that may have been inadequate to realize mental health gain, as a report in the literature as well. So, so then we move on to test the main estimates with a constant sample. So that's the other thing that do our results hold if we take a constant sample across time rather than the 2 subsamples that I was talking about till now. So the prenatal and the postnatal mental health, we included 2 dependent variable lags in the baseline estimations for analyses. And when we include the lags, of course, there's a reduction in a sample. Right. So why they also could be a problem of positive selection into models. For example, women who report mental health every year could be argued to have better mental health on average than ones who don't report mental health every year, which could result in some positive selection into the models with lags, biasing our policy effect upwards. So to study that, we re-estimate using a constant sample of women who report their lagged mental health and current mental health across all models to test the potential bias associated with these things. And what we find is that we have similar policy effects to the baseline estimations. And so it kind of rests our concern that those reporting mental health every year could differ from those who are not reporting mental health every year. The other question that might could be raised is that what happens to mothers who are unaffected by the PPL at all? So if there are mothers who are not affected by these policy, to test whether policy effects were affected by time trends and concurrent policy changes, what we did is that we created groups of employed mothers with older children, and which means aged 5 to 9 years and 10 to 14 years of age, and match the PPL eligibility criteria in terms of the income and the work test. And then we also included mothers who are not in the labor force with newborns. So this was the groups we considered. What we find here is that insignificant policy effect across all.
Yeah, okay.
Yeah, so did you?
Yeah, no, you were muted for about 30 seconds.
Sorry. So what I was trying to say is that for women who would not be affected by the PPL, we created a subgroup which included employed mothers with older children, 5 to 9 years age and 10 to 14 years age, and then match the PPL eligibility criteria in terms of the income and the work test. So that was the first group of people. The other group was, again, into this sample was mothers who are not in the labor force at all, but they do have newborns. So for this analysis, what we find is that there's a insignificant policy effects across all estimations from the test groups. The mental health improvements for eligible women were primarily due to the PPL and the DAPP introduction, we find, rather than any time trends, general policy developments, or any systematic change in the prenatal or postnatal healthcare policies. Like all studies, our study would also have.
You're muted again. Yeah, okay.
Yeah, sorry. So because this is a before and after study, this may not adequately account for the outcome trends and other policy impacts. So, which includes time trends to account for outcome variables in our analyses. We tested policy impact on mothers with children 5 to 10 years of age and mothers of newborn, not in the labor force, and we did not find any significant impact on outcomes. We would need to account for mental disorders in pregnancy and pre-pregnancy as well for an ideal analysis. That we couldn't do in this one. And what we did, however, was that use outcome lags in 2 years. So there was no clear question on whether you had any mental health disorders, but yes, by including the lagged, we tried to do to incorporate this. We don't know from the HILDA data set whether someone took up the PPL or not. All we know is that whether they were eligible or not, right? So there's no clear question on whether they did take up the PPL or not. So we're trying to figure that out from. So women are likely to sign up for PPL if eligible, and a policy impact, not whether someone took maternity leave or not. So that's the other thing that we need to be cautious about. What are the implications of our analyses? The implications are that the PPL did improve the maternal mental health in the case of Australia. And there's a potential to increase the PPL entitlement though. And as I showed in one of the previous slides, to align with places like the UK and Europe, where you've got much more robust policy to further reduce the problem of postpartum depression. PPL improved maternal mental health in mothers who already have access to paid maternity leave. More PPL entitlements would be for mothers without prior entitlement, could further reduce the depressive episodes and improve health equity. Removing the PPL for mothers with private entitlement may reduce maternal mental health as well. And because the PPL and DAPP are complementary, there is also a potential to increase the DAPP entitlements to further reduce the postpartum depression, because our analyses showed strong effects of that. So that's it from me. Thank you.
Thank you very much for a very interesting, yeah, exactly. There's a clap going on around the world. Thank you very much for a very interesting talk, Kompal. There are a few questions in the chat. I think you can access that as well. So if you maybe want to address some of those questions, and then we'll see if people have more. We have about 10, 12 minutes to left. So are you okay? Can you see the questions, Kompal?
Yes, I'm just going through the questions now. So do you control for the number of previous children? So as I showed later on, yes, we did account for a number of births in our subgroup analyses. In the before-after approach, you assume that there is no other time trend responsible for results. Did you check that? Yeah, so we did include the, if I understand the question correctly, we did include 2-year lags in our analysis, but not more than that, because as I said, our sample would shrink big time, and so we need to be a bit. If there are transfers to women from parents which happen because of her health, for example, some transfers, right? And that's an interesting question, Elena. Yes, whether there is information on detailed information on wealth and income, and I think we can look up whether there were any transfers, but whether that will be for that purpose of carers or parental issues is something that won't be clear. But yes, that's a good question. PPO reduces the stress. How does private health insurance mitigate the pressure as well? Out-of-pocket expenses for, yeah. So over there, we have just include the eligibility criteria, whether they have insurance or not, and those kind of things is something that. But the one thing about Australia is that we've got the Medicare over here, so we would need to understand how Medicare and private insurance are going together. But that's a very good question as well. So yeah.
I think the thing about the private health insurance is that access to psychiatric care under the Medicare system is very slow, whereas with private insurance you probably would get access pretty quickly, and that might mitigate some other effects. So I mean, it's just it's an additional kind of effect. It's not the main effect, obviously, that you're talking about.
Yeah. No, I see what you're saying, and I think that's a very good point, because that would and could affect. So we could do a subgroup analysis and see whether access to health insurance. I'm not sure if availing mental health care would be possible in Hilda, but yeah. Why do you think that the first-time mothers are more affected than experienced? Why do you think that the first-time mothers are more affected than experienced mothers? So we had a good discussion. So the three authors have 6 children, among ourselves. And the one thing that we discussed, and this is a good question because we had a good discussion around it, we felt that first-time parents, it's more of a shock. Second time, it's all right. The shock is a bit, lesser. So we thought, and the third time, I don't know, or fourth time, I don't know, how would you categorize those things? But yes, we thought it would be a good thing to see how first-time mothers would take it than experienced mothers, because and as our results also show, the experienced mothers have a different mental health outcomes compared to first-time mothers. So yes, that's something that we have discussed in the paper as well. So what about adoptions? Do they qualify? So when I say babies, the adoptions is also a part of the questions as well. So I think somewhere on the slide I say having a baby or adopted a baby. So we consider both of them because the policy works the same for both. So the PPD should be a hormonal imbalance for women. Adoptions will not qualify. I need to talk to this, John. But could it be used as a robustness check if the sample size was large enough? Yes.
I think John was saying that it's quite small. Number. Adoption is really small.
It's really small. So I think.
But it seems you have other robustness checks as well in terms of
robustness checks. We could try to do that. No, that's a very good point as well. As first-time mothers, more likely to experience PPD more than. I think yes, Roy. At some point, we did feel that they're most likely to experience PPDs, although we've not talked about it in the paper, I think. But the one result that we came across was the birth spacing as well. The birth spacing in subsequent births, in multiple births.
I have another question on this actually. Do you know the sex of the child?
Yeah, we would.
I don't think it has anything to do with PPD, but in certain cultures, if the firstborn is a daughter or a secondborn is a daughter, it may not be like a birth related, but more so the sex of the birth. That might be something, I don't know.
For the PPD, you mean?
Yeah, but I don't know if it's got anything to do with the PPD, but it certainly would cause mental health issues within the mother.
Yeah, but that becomes more of a cultural factor, I think. And as you correctly mentioned, it is prevalent in some other parts of the world, and then in that case, if you're thinking about policies and the places I'm aware of these situations, they don't have robust PPA, PPL policies out there. They're quite weak, and for that kind of analysis, we would need to account for other factors as well, because in those cultures, then you will have more support as well post pregnancy. You might have a lot of people coming in and helping out. So you cannot you cannot segregate those effects, because in a place like Australia and most other OECD countries, having a baby is something that the parents do on their own mostly. I mean, compared to other cultures, the kind of support we're talking about is not that strong, if you know what I mean. And with more people working, it becomes further weakened. So yes, I see your point, but I don't think that's going to be quite relevant for our analysis. So, yeah.
I think Alfonso has kind of related question to that.
Related to previous question, it may be interesting. Yes, heterogeneity structure, we may be able to the data set versus extended family. Yeah. So we had discussions around this, but then we thought we want to focus on just the policy and not how the household dynamics are coming in for the mental health aspect. So yeah, support from extended family, that could be a good follow paper, I think. So yeah, there is literature suggesting that first time mothers are more anxious. Yes, there is literature suggesting there's one paper quite recently I saw where they were talking about data using for Norway, where they found, it's a 2019 paper in JHE, I think, where they're talking about so yes, first time mothers are more anxious as well. So that's all the questions, I think.
We just have another minute or so. Anybody has any other kind of urgent question? You can unmute yourself and ask instead of typing if you feel.
I just have a very simple question. So when you look at your MHI, whatever the index you computed, like you had about 3 or 4 different categories, right? When you ran your ordered probit, or I think you ran an ordered probit or a LOSIT.
So we ran an ordered probit.
Oh, you did, okay. But when you look at the scaling, did you do any robust checks by just scaling your depression scale up or down just to see how the results
so we created those cutoffs. So we used the entire scale to create 4 cutoffs, and the way we created the cutoffs was based on this paper which has suggested how to create the cutoff for that index, right? So if I try to show you yeah, so this paper by Yamazaki in 2005. So we had the MHI and we divided into these four scales for no depression, mild depression. So we didn't go into changing these categories on our own. We just took it from that paper as to how to do it, and just followed the suggestions.
Okay, so that has been used by this particular paper before that.
Yes.
Okay, okay. So if I want to get a copy of your paper, I can email you and you can send me a paper?
Yes, so we will try to upload it with the slides for the GLO, and it should be available. But yes, if you don't find it online, please feel free to write to me.
Okay, so then I have one other very simple question about your DAPP, DAPP, which is for dads. So when that program started, it started much later than the PPL, or was it part of the PPL when they started this program? I mean,
so the PPL was started in 2011, right? And the DAPP came in 2013, and it was complementing the PPL. So it went alongside with PPL when the DAPP was introduced. Okay. So from 2013 onwards, both PPL and the DAPP have been working, whereas from 2011 to 12, a very short period, we just had the PPL.
So as of now, did they relax that quite a bit? I mean, because your data stops in 2016 or 2017, but what happened to these two programs? Are they still going full steam?
Yeah.
Okay.
Okay, I think it's a perfect time to stop. Thank you so much again, Kompal, and perfect timing as well. We're just sort of within the hour time frame. So thank you very much.
Thank you very much. Thanks for having me, Matlub, and thanks for joining all of us here. Thank you so much. If you have any questions, just email me.
Next time we'll talk about cricket, okay?
So that's great. Thanks very much. And thank you to everybody else for asking questions, for participating, for being here. And John and